Hello, ladies and gentlemen. Hello, everyone. Our public education program about the cancer series broadcasting continue. Subject is gastric and esophageal cancer. Gastric and esophageal cancer. Introduction. From 1944 to 2004, 11,261 patients with upper gastrointestinal carcinomas, 6,215 gastric, 5,046 esophageal were treated at the University of Texas MD Anderson Cancer Center. Of these, 5,112, 2,393 gastric, 2,719 esophageal underwent a definitive treatment at MD Anderson. Overall survival OS significantly improved at 5 and 10 years over this 60-year interval. Absolute OS improvements at 5 years were 20.3% of gastric cancer, 11.8 versus 32.1%, and 24.9% for esophageal cancer. 2.3 versus 27.2%. Gastric cancer. In the United States, an estimated 21,130 new cases of gastric cancer were diagnosed in 2009, with 10,620 deaths. According to the surveillance epidemiology and results 2006 database, only 24% of gastric cancer are confined to the stomach localized. 31 to 32% of newly diagnosed cases have spread beyond the stomach into the regional lymph nodes. Regional or other organs distant, respectively. Gastric cancer predominantly affect men at the ratio of 2:1. The median age at the diagnosis is 71 years. The 5-year OS esophageal rate is 25.7%, which has not changed significantly over the past 30 to 40 years. Surgery is still the only chance for cure, and survival can be improved with multimodality therapy. Epidemiologic characteristics. The incidence of gastric carcinoma varies widely both worldwide and within individual country. The highest incidence, greater than 20 per 100,000 in men, is in Japan, China, Eastern Europe, and South America, while the lowest incidence, less than 10% per 100,000 in men. In North America, parts of Africa and Southern Asia, in the United States, gastric cancer occurs at the median age of 69 years for men and 73 for women. African Americans, Hispanic Americans, and Native Americans are 1.5 to 2.5 times more likely to develop gastric cancer than whites. On the basis of SER 2002-2006 data, the age-adjusted incidence of gastric cancer is 7.9 per 100,000 men and women per year. Our source book, MD, the MD Anderson Manual of Medical Oncology. In the United States, the incidence of gastric cancer has been decreasing over the past several decades, reflecting a significant reduction in distal body and antrum disease. The reason for the decline is not known, but may be related to dietary habits, food preservation, and improved surgical morbidity and mortality rates. However, the incidence of proximal stomach and gastroesophageal junction adenocarcinomas has steadily increased at the rate exceeding that of any other cancers, except melanoma and lung cancer. Observational studies suggest that proximal cancer have a different pathogenesis than do distal cancers. Potential causes of distal gastric cancer include Helicobacter pylori infection or E. cadherin expression loss, whereas proximal gastric cancer may behave similarly to distal esophageal and GAG cancer, which progress from Barrett metaplasia to dysplasia to invasive adenocarcinoma. Only 24% of newly diagnosed gastric cancers are localized. The 5-year survival rate of patients with metastatic disease is less than 5%. Thus, even in the United States, despite decreasing incidence, gastric cancer remains a public health concern because of its high fatality rate. Etiologic characteristic and risk factors. Histology of gastric cancer is the most frequently adenocarcinoma, which consists of two main histologic variants, intestinal and diffuse intestinal type. Gastric adenocarcinoma likely begins with a Helicobacter pylori infection that leads to multi-step progression. More than 40 to 50% of distal gastric adenocarcinomas are associated with Helicobacter pylori infection. Studies have shown that different strains of Helicobacter pylori carry differential risk of gastric cancer infection, which was AS1, WAC-AM, and SAC-A positive strains of Helicobacter pylori are associated with an increased risk of gastric cancer. Helicobacter pylori infection probably starts early in childhood and have a long latency period in which the gastric mucosa progresses through the series of well-defined histopathologic steps. Chronic active non-atrophic gastritis, multifocal atrophic gastritis, intestinal metaplasia, dysplasia, and invasive adenocarcinoma. Other environmental risk factors and inflammatory cytokines may influence and contribute to the multi-step progression. Population studies have identified certain environmental risk factors associated with gastric cancer. Low consumption of fruits and vegetables, high intake of N-nitroso compound in the salted and preserved food, preservative, preserved foods, and occupational exposure in coal mining and nickel, rubber, and timber processing are commonly described risk factors. Long-standing chronic superficial gastritis caused by high salt diet or conditions such as pernicious anemia eventually lead to chronic atrophic gastritis and intestinal metaplasia. Gastric atrophy is accompanied by loss of parietal cell mass and thus the reduction in acid production. Parietal cells releasing and pouring acids physiologically. Acid production, hypochlorohydria, achlorohydria if loss of parietal cell. A decrease in luminal ascorbic acid, vitamin C levels, and a compensatory increase in serum gastrin, a potent inducer of gastric epithelial cell proliferation. The increase in the gastric pH would permit colonization by bacteria capable of converting dietary nitrites to potent mutagenic and nitroso compounds. Very important point. Additional notable risk factors include meat consumption, smoking, gastric surgery, and reproductive hormones. A meta-analysis estimated that the relative risk of gastric cancer associated with consumption of 30 g of processed meat per day, about 1/2 an average serving, was 1.15, 95% confidence interval, 1.04 and 1.27. A prospective study found that the smokers were the increased risk of gastric cardia. Gastric cardia is near the esophageal part of our gastric part. And gastric non-cardiac cancer compared with non-smokers, 95%. Two meta-analyses estimated the relative risk of gastric cancer among gastric surgery patients was 1.5 to 3 points depending on the type of surgery, duration of follow-up, and gonographic location. Perhaps one explanation for the lower incidence of gastric cancer among women has to do with the protective effect of reproductive hormones. A recent prospective study from China suggested that there are associations between gastric cancer in women an age of menopause, years of fertility, years since menopause, and intrauterine device use. Overall, the pathogenesis of intestinal type gastric adenocarcinomas involves a series of events. This sequence of events increase cell proliferation due to the promotional effect of hypergastrinoma or bile reflux, increased luminal level of mutagens and nitroso compound and free radicals, and decreased luminal level of protective factors, etc. Vitamin C provides an ideal milieu for carcinogenesis in susceptible hosts. Furthermore, many inflammatory cytokines have been studied to determine whether they are associated with an increased risk of gastric cancer. The most significant association seems to be with interleukin 1 beta. The molecular effect of Helicobacter pylori induced gastritis seems to be associated with interleukin 1 beta pathways and other pro-inflammatory cytokines such as interleukin 10 and tumor necrosis factor alpha. The molecular effect of Helicobacter pylori induced gastritis seems to associate with the interleukin 1 beta pathway and other pro-inflammatory cytokines such as interleukin 10, the tumor necrosis factor alpha. The effect was most likely mediated through the induction of hypochlorhydrin. Chlorhydrin serve corpus gastritis, which leads to subsequent gastric atrophy. Interleukin 1 is unregulated. The presence of Helicobacter pylori and is important in initiating and amplifying response to infection. Excess nitric oxide produced by increased interleukin 1 expression has been shown to be cause of chronic inflammation and contributes Helicobacter pylori induced gastric cancer, and so on. Detail continue, but I would like to stop here and other subject continue. Clinical presentation. At presentation, most symptomatic patients will likely have advanced gastric cancer. Symptoms are generally non-specific and most frequently include weight loss, abdominal pain, and nausea. Dysphagia is more common in patients with cancer originating in the gastric cardia or GEJ. Occult gastrointestinal bleeding is also common, whereas overt bleeding is observed in only 20% of cases. And so many details that some screening photos, figures, endoscopic ultrasound, and different screening methods, but not need public education program. Just superficial. Some different techniques of surgery, surgical oncology, So many ultrasound figure. Post-operative, preoperative therapy. Squamous cell carcinoma. It has become abundantly clear that esophageal squamous cell carcinoma and adenocarcinoma behave differently. Squamous cell carcinoma is typically located in the cervical or mid-esophagus, although squamous cell carcinoma is still the most common. Histologic type is the most of the world. It is rare, less than 5% of esophageal cancer. In the United States, the risk factor for esophageal squamous cell carcinoma are tobacco and alcohol use. The age at diagnosis is typically 10 years younger than that for esophageal adenocarcinoma with proximal and cervical disease. Bronchoscopy is indicated for staging because of the high risk of tracheoesophageal fistule. Different application of treatment, therapeutic modality, systemic cytotoxic chemotherapy. But you know, physicians are this detailed and therapeutic modality. Very, very deep information. Yes, I would like to finish here and pancreatic cancer is another subject. Pancreatic cancer. When clinicians use the term pancreatic cancer, they refer to adenocarcinoma of the pancreas, one of the most challenging malignancies facing oncologists. Today, this disease is characterized by significantly morbidity and poor prognosis. During the course of illness, a variety of problems may be best the patient confront the clinician at the University of Texas MD Anderson Cancer Center. We manage pancreatic cancer patients with multidisciplinary team and view palliation as the primary goal. However, for patients with potentially resectable disease, we take an aggressive multimodality approach whenever medically appropriate in the setting of advanced disease. Cure is not possible, but as our understanding of underlying molecular events involved in carcinogenesis, invasion, and metastasis expands, more effective therapeutic strategies are expected to emerge. Therefore, whenever feasible, patients with advanced disease are treated in clinical trials with special emphasis on targeted therapy. This chapter reviews our current knowledge about pancreatic cancer, including its epidemiology, risk factor, molecular biology, diagnosis and staging, and clinical strategies for current and future therapies. Hard facts about pancreatic cancer. Pancreatic cancer, the most common pancreatic neoplasm, is an aggressive and other rapidly fatal malignancy in the United States. It represents only 2% of all cancer cases but accounts for 5% of all cancer deaths. Currently, it is the fourth leading cause of cancer death, ranking only behind lung cancer, colorectal cancer, and breast cancer, while recent evidence suggests marginal improvements in 5 years survival rates over the last 25 years. 2% in the 1974, 1976, 3% in the 1983, 1985, and 4% in 1992, 1997. Life expectancy remains short and is generally measured in months. Significant improvements in survival have been hampered by a number of factors including inefficient and ineffective screening strategies resulting in frequent presentation with advanced disease, technically challenging and often debilitating surgery, which is commonly misapplied, and minimal effect chemotherapy and radiotherapy. Moreover, pancreatic cancer is dynamic disease and sudden changes in clinical status occur frequently. Patients may rapidly develop worsening pain, biliary obstruction or stent occlusion with cholangitis, gastrointestinal bleeding, thromboembolism, gastric outlet obstruction, or peritoneal carcinomatosis with intestinal dysmotility or intractable ascites. Any of these problems may preclude the timely delivery of cytotoxic therapy and limit opportunities to alter survival. Therefore, most effort should focus on symptom control, but for patients with adequate performance status, treatment is encouraged. Epidemiology. There are approximately 30,000 new cases of pancreatic cancer each year in the United States and 170,000 cases worldwide. Overall, the incidence and mortality of pancreatic cancer are similar throughout the world, but incidence rates are highest in industrialized societies and Western countries. Of particular note is the risk of pancreatic cancer among African Americans, in whom pancreatic cancer mortality rates are higher than for most other ethnic groups in the United States and considerably higher than the rates of African blacks. This finding mimics the epidemiology of colon cancer, a disease in which African Americans also have a substantially higher risk than American white or African blacks. These observations implicate environmental factors conspiring with genetic background as cause of increase in risk. The risk of developing pancreatic cancer is low in the 3 to 4 decades of life but increases sharply after the age of 50 years. At the time of diagnosis, most patients are between the ages of 60 and 80 years. Pancreatic cancer uncommon in patients under 40 years of age, but apparently sporadic cases may rarely occur in patients younger than 30 years. In the past, pancreatic cancer occurred more frequently in men, but incidence and mortality rates in the women have steadily increased, and now the disease is becoming more common in women, probably secondary to the increased use of tobacco by women. Risk factors for pancreatic cancer. Surprisingly, relatively little is known about the risk factors for the development of pancreatic cancer. Tobacco, diabetes mellitus, chronic pancreatitis, diet, body mass index, familial pancreatic cancer, and other genetic syndrome, occupational exposure, prior gastrointestinal surgery. Tobacco. Other than age, the only consistently reported risk factor for pancreatic cancer is cigarette smoking. Cigarette smoking is estimated to account for roughly 30% of all pancreatic cancer mortality. An etiologic role for tobacco smoke has been supported by experimental models which have demonstrated that nitrosamines found in tobacco smoke are carcinogenic for the pancreas. Research performed has shown that smoking-related aromatic DNA, adduct, and other types of DNA damage have all been detected in human pancreatic tissue and may be critical initiating events in pancreatic carcinogenesis. Diabetes mellitus. An association between diabetes mellitus and pancreatic cancer has long been known, although the precise mechanism have yet to be defined, and not all studies have supported diabetes as an definite risk factor. Diabetes has been implicated both as an early manifestation of pancreatic cancer and as a predisposing factor. A meta-analysis of studies published between 1975 and 1994 showed that pancreatic cancer occurred with increased frequency in patients with long-standing diabetes. Diabetes diagnosed at least 5 years prior to the diagnosis of pancreatic cancer or death due to pancreatic cancer. Further recent cohort studies have suggested that abnormal glucose metabolism is associated with the increased risk of developing pancreatic cancer. Our had been declared, published nearly 2012 a fruitful cancer carcinogenesis theory, and our theory, carcinogenesis theory, laws totally four laws. One, mutations grow identity by macrophages. Two, law 2, inadequate energy. Law 3, chronic inflammation. Law 4, normal DNA suppression. All cancers obligatory dependence carcinogenesis mechanism these laws only. All carcinogens and mutagens just only trigger function firstly, but second step, real scenario should have been started. Glucose metabolism associated with an increased risk of developing pancreatic cancer. It is believed that insulin resistance and secondary hyperinsulinism may be involved in pancreatic carcinogenesis with high insulin concentration in the microenvironment of the pancreatic ductal cells contributing malignant transformation. Chronic pancreatitis. As with diabetes, an association between pancreatitis and pancreatic cancer has been suspected, but the clear link remains uncertain. Early clinical studies have suggested that chronic forms of pancreatitis were most closely associated with the subsequent development of pancreatic cancer. For example, in the study of 715 patients with chronic pancreatitis diagnosed between 1971 and 1995, a 13 to 18-fold increase in the incidence of pancreatic cancer was demonstrated. More recent studies have suggested that the type of pancreatitis may affect the risk of pancreatic cancer in the particular hereditary pancreatitis. Lowenfels and Maisonneuve obtained data on 246 patients with hereditary pancreatitis from pancreatologists in 10 countries. The estimated cumulative risk of developing pancreatic cancer by age 70 was approximately 40% in this group. Of note, the mean age at the diagnosis was 57 years. Recent molecular data strongly suggests that mutations in the cationic trypsinogen gene play an important role in hereditary and possibly accurate forms of pancreatitis, thereby increasing the risk for pancreatic cancer. Diet. Positive associations have been discovered between pancreatic cancer and meat and carbohydrate intake. However, there is no general consensus on the role of dietary fat as a factor leading to pancreatic cancer. Epidemiologic studies of pancreatic cancer have shown a protective role for diet high in fruits and vegetables. This effect may be related to dietary intake of folate and other methyl donor groups. Body mass index. Recent epidemiologic studies have also implicated a high body mass index as increasing risk, and current estimates suggest that people with high body mass index have an increased risk of developing pancreatic cancer. This may be explained by relative hyperinsulinemia commonly observed in these individuals and thought to promote pancreatic carcinogenesis. familial pancreatic cancer and other genetic syndromes. Familial pancreatic cancer and other genetic syndromes. Another emerging risk factor for pancreatic cancer is familial history. Pancreatic cancer patients who have two first-degree relative history of pancreatic cancer are defined as having familial pancreatic cancer. The relative risk for other family members has been estimated to be increased 10 to 20-fold over the general population. In addition, several genetic syndromes are associated with an increased risk of pancreatic cancer, including hereditary pancreatitis, hereditary non-polyposis colorectal cancer, ataxia telangiectasia, Peutz-Jeghers syndrome, familial breast and ovarian cancer, and familial atypical multiple melanoma. Occupational, professional or job, occupational exposure to carcinogens in the workplace has been implicated in the etiology of pancreatic cancer, but with the possible exception of formaldehyde, the available evidence is insufficient to identify any specific exposure as likely to substantially increase the risk. Prior gastrointestinal surgery. Surgery procedures such as gastrectomy and cholecystectomy have been reported to increase pancreatic cancer risk and are possibly linked to elevated levels of cholecystokinin and hypergastrinemia. However, other studies have not demonstrated such as clear risk. Linking risk factor of molecular events, human pancreatic carcinogenesis. So many detailed pathology, clinical presentation. The clinical presentation of pancreatic cancer is primarily dependent on the location of the tumor within the pancreas. The majority, 85% of pancreatic cancer develop within the pancreatic head. About 10% are located in the pancreatic body and 5% in the tail. Non-specific, poorly localized epigastric or back pain of autonomic origin in the most common initial presentation of pancreatic cancer. It is usually caused by invasion or compression of the celiac, splenic or mesenteric plexi. Tumors in the head or neck of the pancreas typically cause pain in the epigastric area on the right upper quadrant of the abdomen. Cancer of the pancreatic body may cause unremitting back pain, and tumor in the pancreatic tail are associated with left upper quadrant pain. Painless jaundice, another common presentation, is generally associated with tumors in the pancreatic head or uncinate process. Jaundice may be the only complaint. It is usually precipitates immediate medical evaluation and subsequent diagnosis, which may result in the discovery of small potential resectable primary tumor. In contrast, when the tumor does not arise in proximity to the intrapancreatic portion of the bile duct, diagnosis may be delayed and characterized by abdominal pain or back pain without jaundice. Acute pancreatitis, while not common, can be caused by ductal adenocarcinoma is patient with no other reason for acute pancreatitis, lack of gallstone, no history of alcohol or other precipitating drugs, and underlying pancreatic neoplasm should be considered. Symptoms of chronic pancreatitis are relatively common, however, and include diarrhea, bloating, or constipation, abdominal distension, and weight loss. Last patient with tail lesions, often present with signs or symptoms of metastatic disease, including pain over the liver, night sweats, anorexia, and weight loss. Diagnosis and staging of pancreatic cancer. Treatment strategy for pancreatic cancer, so many details. Just suitable doctors, physicians. Yes, that's all here. Hepatobiliary malignancies. Hepatobiliary malignancies. Hepatobiliary malignancies. Yes, hepatobiliary malignancies comprise diverse group of tumors, include hepatocellular carcinoma, variants such as fibrolamellar hepatocellular carcinoma and cholangiocellular carcinoma, cholangiocarcinoma, carcinoma of the gallbladder, and rare cancers such as sarcoma, angiosarcoma, and hepatoblastoma. The relative frequency of these tumors is shown in table 19.1. The estimated new cases and deaths from liver and intrahepatic bile duct cancer in the United States in 2009 total 22,620 and 18,160 respectively. The majority of primary liver tumor are hepatocellular carcinoma or cholangiocarcinoma. These tumor types have different etiologies, epidemiologies, clinical presentation, and treatment options. Thus, they are discussed separately. Hepatocellular carcinoma. Hepatocellular carcinoma is malignancy of worldwide significance and has become increasingly important in the United States. Hepatocellular carcinoma is the most common primary liver malignancy, the sixth most common cancer, and the third most common cause of cancer-related deaths worldwide. 80% of new cases occur in developing countries, but the incidence is rising in economically developed regions, including Japan, Western Europe, and the United States. The worldwide distribution of hepatocellular carcinoma and its associated etiologies are summarized in table 19.2. Liver cirrhosis is the seventh leading cause of death in the world. The 10th most common cause of death is in the United States and acknowledged as a premalignant condition. for developing hepatocellular carcinoma. In the United States, hepatitis C virus, alcohol use, and non-alcoholic fatty liver disease are the most common cause of cirrhosis. The incidence of hepatocellular carcinoma doubled during the period of 1975 to 1995 and continued to rise through 1998. This trend is expected to continue due to estimated 4 million hepatitis C seropositive individuals in the United States and the known latency of hepatocellular carcinoma development from the initial hepatic C virus infection, which may take 2 to 3 decades. It is also known that non-alcoholic fatty liver disease associated cirrhosis is on the rise in the United States. A majority of patients present with advanced disease that is not amenable to curative procedures. Overall, hepatic cellular carcinoma has a very poor prognosis with a 5-year survival rate of 5%. Hepatocellular carcinoma varies significantly by geography. It is endemic in the part of the world where hepatitis B virus is also endemic. In Western countries, hepatic C virus infection and alcoholic cirrhosis are the principal risk factor for hepatocellular carcinoma. Due to the rising incidence of hepatocellular C virus infection in American subpopulations, the incidence of hepatocellular carcinoma is projected to increase fourfold by 2015. The incidence of hepatocellular carcinoma increases with age, with the age of peak incidence varying somewhat with population. The median age group of hepatocellular carcinoma is between the 5th and 6th decades. Hepatocellular carcinoma is seen in children and young adults in areas where hepatic B virus is endemic, and most of these infections occur perinatally in all populations worldwide. There is a strong male predominance in hepatocellular carcinoma incidence in the United States. The male to female ratio is 2.7 to 1 among African Americans, then Caucasian 6.1 versus 2.8 per 100,000 in men. Hispanics, Asians, Pacific Islands, and Native Americans have a much higher hepatocellular carcinoma frequency. Independent of hepatic B virus status, family history of hepatocellular carcinoma in first degree relatives carries a relative risk of 2.4 and overall risk 2.9. Familial aggregation and germline mutation of the APC, adenomatous polyposis coli gene have been reported in hepatoblastoma. Etiology and risk factors. Hepatocellular carcinoma develops commonly but not exclusively in a setting of liver cell injury, which lead to inflammation, hepatocyte regeneration, liver matrix remodeling, fibrosis, and ultimately cirrhosis. The major etiologies of liver cirrhosis are diverse and include chronic hepatic B virus and hepatic C virus infection, alcohol consumption, certain medication or toxic exposure, and genetic metabolic disease. The mechanisms by which these varied etiology lead to hepatocellular carcinoma are not fully elucidated. The principal risk factors that have been associated with cirrhosis and hepatocellular carcinoma are listed in table 19.3. Chronic viral hepatitis, aflatoxin, alcohol, and cirrhosis. Other environmental factors. Chronic viral hepatitis. Chronic hepatitis B or C viral infection is the most important risk factor for developing hepatocellular carcinoma. Hepatitis C virus alone causes about 40% of hepatocellular carcinoma in the United States. Chronic hepatic B virus or hepatic C virus carriers usually take 10 to 20 years to develop hepatic cirrhosis and 30 to 40 years to develop hepatocellular carcinoma. Hepatic B virus is a DNA virus that commonly integrates into the host hepatocyte genome and may play a direct pro-carcinogenic role. Hepatocellular hepatic C virus is a RNA virus with no insertional mutagenesis, although hepatic B virus and hepatic C virus contain non-known viral oncogene to immortalize hepatocytes. Hepatitis B X antigen may inactivate p53 protein and downregulate DNA repairability. Some of the principal differences between hepatic B virus and hepatic C virus associate hepatocellular carcinoma. Alcohol and cirrhosis. Excessive alcohol consumption can lead to hepatic cirrhosis and thus is the risk factor for hepatocellular carcinoma. The autopsies of patients with alcoholic cirrhosis have reported up to 10% undiagnosed hepatocellular carcinoma in the United States. Alcoholic cirrhosis is associated with about 15% of hepatocellular carcinoma and cholangiocarcinoma. In hepatic C virus carriers, alcohol increases circulating hepatic C virus viral titer and hepatocellular carcinoma risk. Other types of cirrhosis and parenchymal liver disease such as primary biliary cirrhosis, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, and glycogen storage disease significantly increase hepatocellular carcinoma risk when alcohol is a cofactor. Aflatoxin. Food contaminated with aflatoxin and mycotoxin found in grains can induce hepatocellular carcinoma in animals. There is also a strong association between aflatoxin exposure and hepatic B virus carrier status. Relative risk of hepatocellular carcinoma are 3-fold for aflatoxin, 9-fold for chronic hepatic B virus infection, and 59-fold for concurrent aflatoxin and chronic hepatic B virus infection. The underlying mechanism is polymorphism variants of glutathione S transferase M1 and epoxide hydrolase genes and G2T point mutations of the p53 gene. Other environmental factors. The use of oral contraceptive pills significantly increases the incidence of benign hepatic adenoma. There is some evidence that oral contraceptive pills also increase hepatocellular carcinoma risk. Multiple studies on tobacco smoking and hepatocellular carcinoma risk have yielded mixed conclusions. Occupational exposure to arsenic or vinyl chloride significantly increases the risk of liver angiosarcoma. Exposure to the X-ray contrast medium thorium dioxide from 1930 to 1955 is associated with an extremely high risk of hemangiosarcoma, cholangiocarcinoma, and hepatocellular carcinoma. Clinical presentation. Most cases of hepatocellular carcinoma are identified incidentally or through screening program of high-risk individuals. It is common for patients to be asymptomatic until their disease is very far advanced. Less than 30% of patients are candidate for surgery or other liver-direct therapy at presentation. Many patients present with symptoms of advanced liver dysfunction from both cirrhosis and hepatocellular carcinoma. The most common initial symptom is right upper quadrant abdominal pain. Anorexia or early stage with weight loss is the second most common symptom. Hepatocellular carcinoma may present with various paraneoplastic symptoms through the secretion of numerous hormones. Late-stage symptoms include jaundice, tumor, fever, bone pain due to metastatic lesions, and the complications from portal venous hypertension, such as esophagogastric varices, hypoalbuminemia, ascites, thrombocytopenia, and coagulopathy. On physical examination, hepatomegaly is present in over 90% of patients. The hepatic arterial fluid or the friction, rub, ascites, splenomegaly, and jaundice are found in up to 50% of patients. Muscle wasting, fever, and dilated abdominal veins are also quite common. The Bucchiari syndrome is caused by malignant invasion and occlusion of the hepatitis veins. The hepatocellular carcinoma marker, alpha-fetoprotein, is often elevated to about 400 nanogram milliliter. Pathology and different histopathologic figure and autopsy. Gross pathologic specimen multifocal hepatocellular carcinoma show us diagnostic evaluation, staging and prognosis, treatment. Different therapeutic modality. Yes, another subject, carcinomas of the gallbladder and biliary tract. Epidemiology, there are about 8,000 newly diagnosed cases of cancer of the gallbladder and bile duct annually. in the United States. This rate has remained stable or increased slightly over the past 3 decades. These cancers account for 15-20% of the primary hepatobiliary malignancies. They are most frequently diagnosed in the patients in their 60s and 70s and are more common in the female with an overall female to male ratio of 2.5 to 1 to 15 to 1 for those under the age of 40%. The incidence in American Indians is 6 times higher than in the remainder of the population. Autopsy and operative data suggested a prevalence rate of 0.5 to 2%. Cholangiocarcinomas are classified as intrahepatic, hilar or distal, extrahepatic, intrahepatic. Cholangiocarcinoma is the second most common primary hepatic malignancy and is the increase in the incidence in the United States. This is at least partly explained by the redesignation of liver metastasis of unknown primary to intrahepatic cholangiocarcinoma. It arises from the epithelium of the intrahepatic bile duct and consists of well-differentiated adenocarcinoma cells. Etiology and risk factors. Chronic cholelithiasis and cholecystitis are closely associated with gallbladder carcinoma. The relative risk is 2.4-fold for patients with stones, or 2.0 to 22.9 cm, and 10-fold for stones greater than 3 cm in diameter. Chronic cholecystitis induces adenomatous polyps which can undergo malignant transformation. Environmental carcinogens include methylcholanthrin and nitrosamines. Other risk factors are listed in tables shown. Clinical presentation. Primary gallbladder cancer is incidentally found in 0.4 to 2% of laparoscopic cholecystectomy procedure. The most common symptoms and signs of gallbladder carcinoma are non-specific right upper quadrant, abdominal pain, and tenderness, which are also frequently seen in the cholelithiasis or cholecystitis. The clinical features of the cholangiocarcinoma vary from hepatomegaly and upper abdominal pain with intrahepatic tumors to the rapid onset of painless deep jaundice with hilar tumors. Intrahepatic tumors often present at a more advanced stage due to the non-specific nature of symptoms. Serum tumor markers, specifically CA19, CA19, 9, and CA125 are frequently elevated but not pathognomic for biliary tract cancer. Pathology, staging and prognosis, and treatments. Yes. That's all this program finish at this points, and we will be continue another program, and our next program subject small bowel cancer and appendicial tumor. Thank you very much. Thank you so much. Your patience. See you later.